Hello, everyone. Welcome to our webinar this evening. We're so glad that you're here tonight to join us for a discussion on navigating overactive bladder and urge urinary incontinence. My name is Sarah Jenkins, and I'm the Executive Director of the National Association for Continence, and I'll be helping guide this discussion this evening. This is really just such an important conversation because bladder symptoms are incredibly common, and yet so many people still feel like they need to deal with them quietly or alone. So tonight's really about education, support, and helping people find the treatments and options that are available. So here's a quick look at where we're headed tonight. We'll begin by introducing our keynote speaker, Dr. Susan Oakley. And later in the program, we'll also hear a patient perspective from Amanda McCullough. Along the way, we'll also talk about what overactive bladder and urge urinary incontinence are, and just as importantly, what they're not. We'll also touch on the role of specialists like urologists and urogynecologists, why treatment isn't always a straight line, and hear a real patient story about how to feel confident in advocating for treatment. And then if there's time at the end, we'll have a live Q&A. If you do have a question during the presentation, just drop it in the Q&A box below. There should be a little button at the bottom of your screen, and we'll get to them at the end. So it is my pleasure to introduce our keynote speaker for this evening, Dr. Susan Oakley. Dr. Oakley is a board certified urogynecologist with fellowship training in female pelvic medicine and reconstructive surgery. She specializes in complex pelvic floor disorders, including incontinence, prolapse, overactive bladder, and pelvic pain. She is an expert in both minimally invasive surgical and non-surgical treatments, and she is also a national speaker and educator in women's health. She's a North Carolina native and proud Tar Heel, and her medical journey has taken her around the world from Israel and Africa and even Central America. She's now based in Cincinnati with her husband, two daughters, and their dog, and we're incredibly lucky to have her with us tonight, and you'll be hearing from her in just a few minutes. We'll also be hearing later in the program from Amanda McCullough, who will share her perspective as a patient. Amanda is 62 years old and has been married for 26 years. She's a proud mother of three, a stepmother to two bonus daughters, and a devoted grandmother of four. This June also marks an impressive milestone for her, 30 years of dedication to her career. She treasures her family, and they are clearly at the center of her life. We're very grateful that she's joining us and will be sharing part of her story this evening. So for anyone who may not be newer to NAFC, the National Association for Continence was founded in 1983 and is the oldest and largest nonprofit organization dedicated to helping people living with bladder and bowel incontinence. We provide trusted education, support, and resources for millions of people. In fact, we reach about 2.5 million people annually through our website, and we offer information on diagnosis, treatment. We have downloadable resources, a newsletter that you can sign up for, social media content, a podcast, and an active community. At the heart of it all, NAFC really exists to help people feel informed, supported, and less alone. At NAFC, our mission is rooted in something very simple, but really powerful, helping people know that they are not alone and that they deserve support. Incontinence affects more than 100 million Americans, yet for many people, they remain silent, often wrapped in embarrassment, stigma, and isolation. Many people actually wait years before seeking help. That's why education matters so much to us. We work to empower patients with trusted information, shared stories, and a compassionate community. So we're not just a resource, we're also a voice for change, advocating for better care, better products, and a space that talks more openly about bladder and bowel health conditions. So if bladder symptoms are affecting your quality of life, we want you to know that you deserve more options. And that's really brings us to the heart of tonight's conversation, understanding what overactive bladder and urge urinary incontinence actually are and how they affect daily life and what people can do next. So with that, I'm happy to turn things over to Dr. Susan Oakley.
Oh, thank you so much, Sarah. You have really grounded us in our mission for tonight. And I'm just so thankful each and every one of you have decided to join us for this really important conversation. I want us to all be intentional and deliberate about what we're discussing. I also want us to feel the freedom to interrupt and ask questions. Of course, I'm so thankful to Sarah and the NAFC for inviting me to engage in this opportunity to bring awareness and education to urinary incontinence. And I'm super appreciative of Medtronic for suggesting me as the speaker tonight. And kudos, obviously, to Holly from the NAFC for the Living Without Leaks podcast, because that's an incredible adventure, I think, for the NAFC. And so if y'all haven't tapped into that, make sure you do. So y'all really want to hear from Amanda tonight. She is our keynote patient, and she's going to be sharing her journey with all of you. And I think that's really the most important. But I get to say all the background data, and that's, again, going to center us in the conversation tonight around urinary incontinence. So forgive me for my lack of tech savvy skills, but I'm going to try and advance the slides. And so with, thank you so much, Sarah, if you're helping me. But with urinary incontinence, I want all of you to understand that there really are three main types, and you might see more than three that are up on the screen for you. But in general, one is called stress incontinence. And stress incontinence is the leakage of urine when you do something stressful. So you have to be actively coughing like you might be doing now during allergy season, right? Or jumping on a trampoline, which a lot of you have already said no to. And again, you're doing something that is high impact, like running or CrossFit, sneezing, jumping, and that causes the urethra tube, or what I like to call pee hole, to just pop open, right? Your pee hole should not be popping open. But if it pops open during stress, then you wet your pants. And that's where we get the term stress incontinence. There's another kind of leakage that's called overflow. Overflow is when we honestly have such a full bladder. The leakage occurs because we're sort of skimming off the top, right? You're just walking around with a full bucket. And no matter how you bend or move or don't do anything at all, it just sort of squirts out. And that may be something related to an underlying medical condition. But the focus of tonight is really that third type of incontinence, and we call that urgency incontinence, where you have the urgency to go so badly, you just can't make it, right? You can't get the keys out of the purse fast enough. You can't get the door open fast enough. You're about to drop all the grocery bags that you have carrying into the house because you're going to wet your pants. And it happened to me this morning, right? I went out for my 3-mile run and I'm fine. I don't have any stress incontinence, but y'all, I could not get in the garage door fast enough. It started coming out before I could get my pants down in the bathroom. Now, you may be experiencing warning signs before that incontinence or leakage of urine starts. And those warning signs are frequent trips to the bathroom. You think, well, I'm just going to pee before I leave the house. Well, I'm just going to pee when I get there. And then I'm going to pee again and again and again. And you're creating a sense of frequency because there's an underlying urgency. So you can actually have mixed incontinence, and it can be a little bit about all the things. And that is not uncommon. I take care of women for a living, but men and women and children can experience all these types of incontinence. And then, Sarah, if you feel the need to click forward, go for it. You're being super helpful for me. And I always like to tell my patients that this type of urgency incontinence or overactive bladder is really related to two main categories: muscle and nerve, right? So the nerve signal is from your brain. It goes all the way down the back of your spinal cord, sort of ending in the tailbone. And that nerve tells that bladder muscle what to do. So when there's a misfire of that nerve because of innumerable medical conditions or medications that we take, then we can get the urgency to pee, or you may not even be aware of the urgency. That nerve's just telling the muscle to squeeze the pee out without awareness, without warning, and certainly without your consent, right? And you can see that you're not alone. 1 in 3 Americans will suffer from this type of bladder leakage. So it is extremely common. Now, overactive bladder, like we were saying a moment ago, is really just those warning shots. Sometimes we do get warning signs with a lot of medical conditions. Sometimes we don't. But in this case, that feeling of urgency, that feeling of frequency, maybe a little irritation in your bladder, that is your bladder saying, you're going to wet your pants if you don't mitigate these symptoms now. I always laugh and throw my mother under the bus, because she probably complained about this for 10 years. And I thought, Mom, just take the medicine. It will work. And she thought, well, I'm not wetting my pants yet. And we women have a tendency to put things off, right? We take care of ourselves last. But if you get nothing else out of tonight's webinar, get this. If you're having these warning signs, take care of it now. If this were something very worrisome and egregious, for example, breast cancer, I don't think any of our listeners would say, it's stage 1. I'll just wait and treat it when it's stage 4. I really doubt any one of you would say that. And so overactive bladder is almost like stage 1 of incontinence. They're the warning signs, and it's best to sort of get in on this while you can. And since our treatments are very simple, there's no reason why women, men, and children can't go ahead and try some of these treatments. But you can see those key symptoms there, that strong need to urinate often. Usually we say more than 8 to 10 times a day and more than twice at night. Nighttime's always the most difficult to talk about when it comes to overactive bladder, because y'all are probably like me, right? I mean, my husband snores, so I wake up anyway and I'm like, I'm awake, I guess I'll go pee. Or my dog wakes me up, right? The CPAP machine wakes me up. And so, but what we mean to say with overactive bladder is it's truly just the bladder, not the dog, not the husband, not the CPAP machine. But if you're waking up more than twice at night and going more than 10 times during the day, again, overactive bladder with leakage is called urge incontinence. So that sudden, intense urge to go accompanied by wetting your pants is the type of incontinence we want to focus on today during this webinar. And again, Amanda and Sarah and I are so grateful all of you have tuned in to learn about this. So again, put questions in the sidebar. We're happy to get to some of those intermittently or at the end. But a lot of times you might just turn the water on because you're washing the dishes after supper and you think, oh my Lord, the pee's running down my leg. Or maybe you really are out for a walk or a run and you've got to jump behind a bush on the sidewalk and pee. I was just home in South Carolina and I giggle at how my mother-in-law, my mom, and I all take care of this urgency incontinence on the beach. I'll be honest, I just sit in the sand dunes and I'm like, let it come out. It'll dry up in 2 seconds. It's the South. It's so hot. And, my mother-in-law, she's like, I'll just casually do it in my beach chair. No one will notice. And then my mom, she's like, I'll just sit at the water's edge and let it trickle out. So, you're not alone. We've all figured out workarounds, but let's talk about a little evaluation and management because there are really easy ways to mitigate this, like we said. Y'all should know that there are certain risk factors. A lot of times we I think my patients ask, well, why did this happen to me? And sometimes you're right. It just happens because of age. And no one likes to hear that, right? I don't like to hear that my skin is saggy, my hair is falling out. And my heart's failing and my bones are brittle because I'm old. I'm tired of hearing that the reason is because I'm old. But I think we know that inherently, right? I'm not driving the first car I ever had. I'm not carrying the first purse I ever had. I'm not wearing the first pair of shoes I ever bought. And so things do wear out, including nerves and muscles. And when those nerves and muscles to the bladder wear out, that's how we kind of get incontinence with age, whether you're a man or a woman. It is more common in women. Why? Because we may experience things like trauma to our pelvic floor through procedures or even childbirth, whether that's vaginal delivery, forceps, C-section. And urge incontinence is more common with a cesarean section delivery. We're essentially cutting through those layers near the bladder, and that can irritate the nerves and muscles going to the bladder. And a lot of times, urge incontinence, again, is caused more by a heightened irritation in the nerves and muscles, not necessarily a weakness. Menopause can be a main etiology. You know, we start losing that estrogen at age 35. Sorry, everybody, it's true. And when we lose that estrogen, we lose the integrity to a lot of skin, ligament, tendons, and muscles. Now, in men, obviously, prostate enlargement, called hypertrophy, or even prostate cancer, can lead to incontinence, particularly with urgency and frequency. And then I always like to point out again those true nerve issues, because we were saying nerve is one of the categories with muscle, right? So anything up here, all the way down the spinal cord. So if we're just throwing things out, that can be dementia, Alzheimer's, Parkinson's, a history of a small mini stroke called a TIA, a full stroke. You can have multiple sclerosis. You can even have a herniated disc in the back of your cervical spine or lower back, lumbar and sacral area. You could have been born with spina bifida or a meningeocele. You could have scoliosis in that sort of spinal cord or spinal column. So there are so many things that sort of irritate and twist and grate on that nerve back there. Medications as well, big risk factors for urgency. A lot of times it's going to be things like steroids or diuretics called water pills, hydrochlorothiazide, Lasix. Some of y'all might be on those. And then, of course, anything that irritates the bladder. And y'all know how I like to talk about this on my podcast and social media, but no to the C words. So no caffeine, no carbonation, no citrus, and no dark chocolate, because it has a lot of caffeine in it. This is where people want to argue, well, can I half cap it? Can I decaf it? And y'all know you can't squeeze caffeine out of a coffee bean or a tea leaf. So it's best to just drink half your body weight in water. But let's see, Sarah, what's on our next slide. Oh, yes, I love this. The common myths, right? How many women have said to me, oh, it's just because I had kids. Y'all, if I had a nickel for every one of you that said that to me, I'd be a billionaire. But you see it up here. You've probably said this. I know I've said it, right? Oh, it's just aging, or, oh, there's nothing out there for me. Oh, it's just surgery. I don't want to talk to that Dr. Oakley. She's a surgeon and I don't have time for that. I also have heard, well, I trust my family doctor, right? My primary care helps me with everything. And he didn't mention this. He didn't say there was anything. Just do Kegels. So lots of myths out there surrounding incontinence. And we want to throw those out the window with that stigma that Sarah mentioned at the beginning, right? Tonight, we want to get real. So let's get real with some of those treatment options. Now, how great is it that we have options, right? I mean, I always love it when my women come in and they're like, well, I don't like medicine and I don't have time for surgery. And then I always like to pull a little drawer open in my exam room and I say, oh, yes, no, the magic drawer. Oh, it's fresh out. Yeah, we're out of magic. Sorry, y'all. And there is no magic. There's not. So there will be good and bad per se to all the treatment options, but it's nice we have options, right? So it's almost a shame to not pick something because there is benefit to all of these, right? The first line of defense is just Are we seeing those warning signs with overactive bladder and urgency and frequency? And can we just prevent the incontinence? Are we in the early stages of leakage? And can we prevent it from getting worse? Absolutely. Right? So that first line of defense is really behavioral modifications. So first and foremost, there are some research papers to say an 8 to 10% weight loss can help with overactive bladder and urgency incontinence. But then again, you've got patients who are 80 pounds soaking wet and they have terrible incontinence. So that's not in and of itself a very successful treatment, but it might be with some of the other behavioral modifications like diet. So really drinking half your body weight in plain pure water every day, none of that Crystal Light flavored colored water, right? You just want that crystal clear water. The water you drink, can be in a bottle distilled out of your tap if you're in an area where you feel like it's potable and safe. And then bladder retraining is amazing. I don't know how many of y'all have ever kept, say, a weight loss diary, but a bladder diary can be very similar in its helpfulness for you. So sometimes when I get my little notebook, like I've got right here, I love a good notebook. And if I take that notebook and I write down what I'm eating, even if it's just a mint or an M&M, I am held accountable to what I'm ingesting. And if you keep a diary like that for your bladder and log, what are you drinking? What time of day are you drinking it? And when are you having the urgency to go? Along with how strong that urgency is and whether it's with leakage or not. It really will hone you in on triggers. I know that if I drink orange juice as a citrus, I'm fine. But if I drink a lot of seltzers and things like this, I'm going to wet my pants in 2 seconds. So again, a bladder diary to help you retrain yourself is a great idea. I consider pelvic floor physical therapy a first line treatment as well as a prevention, and it's never too late. So most every other country in the world really advocates for women to undergo pelvic floor physical therapy very early on, right? You may even hear from Amanda that her symptoms started 25 years ago, right? So when other countries are sending their 20 and 30-year-olds to pelvic floor physical therapy, let's say before they've ever been diagnosed with medical conditions or had a baby or had cancer, right? Then they're really learning how to control that pelvic floor and utilize certain techniques to prevent incontinence from ever occurring. We're a little behind in America. So with our American listeners tonight, we just really want to encourage y'all to do pelvic floor. And again, if you missed it in your 20s, 30s, 40s, and you want to start in your 50s like me or in your 60s like Amanda, I think it's fine. Medications are another line of defense or treatment. Again, they can be started with overactive bladder and no incontinence, or they can be started if you're leaking so bad with urgency right now, you're in a diaper. So again, all things that can be started no matter where you're at in your journey and on the spectrum of maybe disease severity with the leakage. So we have really two groups of medication. One is called anticholinergics. It's been around forever, and I'm sure I'll get some questions about that tonight. And the other group is called beta agonist. They're very similar. They just sort of attach themselves to these little chemical receptors on the lining of your bladder muscle. And it just sort of calms it down, right? So we're just looking for ways to calm down the overactivity of the bladder muscle so it's not giving you the urgency or spasm, and it's not just pushing pee out without your consent or warning. Anticholinergics are typically less expensive, ubiquitously covered by most insurance companies in the United States. Beta agonists usually are pricier, but one just went generic and may be covered by your insurance plan. So oftentimes when your doctor prescribes one, they're really just trying to give you something that they think will work with few side effects, but they may not know the coverage, and that may be something you need to call insurance for. Vaginal estrogen is another prescription, just like the pills I was talking about. And I love estrogen cream. I use it every night. If y'all listen to my podcast, you know how much I love it. A little dab will do ya. So estrogen cream comes in a big toothpaste-sized tube. It's usually about 42 grams, and it runs about $100, but it will last you a whole year. And just a little pea-sized amount on your fingertip, and you want to rub it right at the opening of your pee hole or urethra where the pee comes out. And if you do that every night, it decreases a lot of urgency, frequency, irritation, keeps a good pH balance as well to prevent things like urinary tract infections. And Botox is another great medicine, very similar to the pills. It calms the muscle spasms. Botulinum toxin is a paralytic. And that's why women inject it in their face to paralyze the muscles so they don't scrunch and wrinkle up. And we can inject Botox into the neck for migraines and into the bladder for that urgency and frequency and to relax the spasm so there's no more overactive bladder or incontinence. Now, Sarah, the nerve things, I think we discussed those in more detail, right, on the coming slides? So before we talk about those amazing nerve therapies, especially as offered by Medtronic as a company here in America, we want to just review that treatment care pathway. Always remember to advocate for yourself. And Amanda, our patient who's featured tonight, is really going to pull your attention to that piece of this puzzle, right? So there's shared decision making, and you speak up, and you speak up when you feel comfortable and confident. But as you can see on the wheel of therapy, lifestyle changes and medications, and sort of the darker blue at the top, and then maybe moving towards more procedural types of treatments like injections of Botox. Most all of these can be done in an office setting, are covered by insurance, and are easy with really low risk and a very high yield or high success. The treatment pathway is different for everyone. And Amanda's, her story probably includes all of those treatments, to be honest, which is why it's really good she's speaking to this tonight. But if you remember those two main buckets or causes of urgency incontinence, muscle and nerve, some people really may do better with a muscle treatment like oral medications, which are the pills, or injectable medications, which would be considered Botox. Now, if you're a person who really suffers from the inability to empty fully, or you get a lot of urinary tract infections, we may push you more towards a nerve therapy instead of a muscle therapy. So you're right, the treatment path is different for everyone. Symptoms are so variable. And like we said at the beginning, you may have a little bit of all the types of incontinence. So what may work for Sarah may not work for me. And what works for me may not work for Amanda or all of you. And please remember that your choice is super important. But if you're confident and comfortable with your care provider, like me, for example, I want to use my expertise and knowledge to sort of mold that choice and guide you. But in general, as a care provider, I'm always willing to try what it is you have a preference toward, even if I have a preference towards another one. Just because, again, it's okay to try things. Treatments, they don't fail, right? You and your care provider just keep sort of modifying the plan until you find the thing that helps. I think a lot of patients lose faith in us when we give one pill, and within 48 hours it doesn't work, and again, it's not magic. So we always want to give each of these treatments at least 6 to 8 weeks to really work and be effective before we throw the towel in. Now, we call this third line treatment, but honestly, a lot of these are second line options because women may have tried pelvic physical therapy, changed their diet, and mentally retrained their bladder along with trying a couple of different pills. And so I kind of see all of that as first line, and then they're allowed to move to second line. But based on insurance, right? Your insurance is sort of the store you shop at. So I always like to tell my patients, if you want to find out the price of apples, you kind of need to call your store. So a bag of apples at Kroger may be $5.99, and that same bag of apples at Costco may be $3.99. And that's how insurance companies work. So where you shop, right, for your healthcare is your insurance company. And your insurance company may call nerve modulator therapies third line, whereas a different person's insurance may call them second line. So you just have to reach out to them to see what's covered. But basically, all the nerve treatments are just modifying that signal we talked about from your brain down your spinal cord into the tailbone. And that therapy helps restore the communication. I don't know, I'm almost 50, but some of y'all may remember the old switchboard operators, right? Like when you really had to pick up a phone before even the rotary phone. And you had to say, connect me to the fire station. Well, if the switchboard operator made one false move, you weren't connected to the fire station, right? You went to the bulk department store instead. And that miscommunication, that's critical, right? And so the same thing's happening in the nerves between our brain and our bladder. And we need to restore adequate communication and really connect the dots like the switchboard operators used to do. So usually these are done with a gentle electrical stimulation. I can't say it's anything you would ever feel, honestly. So I don't want anybody to be alarmed by this description. Again, it's so gentle, I really don't think it's even perceivable, except maybe when we as the care provider are actively installing it or doing it for you. But it, again, resets the nerve to reduce your awareness of urgency. You'll get a signal, it'll be normal. You can hold your bladder for 5 hours like a normal lady, sleep through the night. Oh my Lord, right? And when you get that normal signal, you'll have plenty of time to make it to the restroom to empty your bladder. And so these neuromodulator therapies are used when the first line therapies fail you, or, you just were okay with the pills, but didn't like the side effects and you're ready to move on. And you can see 3 of the main types here. These are branded. They are offered by a company called Medtronic, which you'll see in the top picture there. There are other companies, just like there are different shoe companies from Nike to Adidas and different people that make tissue from Kleenex to Scott to Puffs, right? But Medtronic is a brand that I've been using for over 15 years. And these 3 therapies I do frequently. The first is a neuromodulator or small little battery implant that you see in the top picture, placed in your tailbone or sacrum. And that's why we call it sacral nerve modulation or SNS. The second one is, again, an external small electrical device or battery attached to the nerve through your skin with a very gentle small acupuncture needle. This is called PTNM or percutaneous tibial nerve modulation. The neurosystem is usually done on a weekly basis on the outside of your skin in an office setting with a medical assistant or nurse. You don't need a nurse practitioner or physician for this therapy. A lot of women feel coming in every week might be cumbersome, especially if they require a copay through insurance. But otherwise, it's non-invasive. They can read a book for 30 minutes as they undergo the treatment each week in the office. So it's very comfortable, nothing that they feel pain from. And this is delivered through the skin with an acupuncture needle on the tibial nerve, which is actually inside your ankle. So that nerve we were talking about in your brain goes all the way down your spinal cord, comes to the tailbone, and then sort of shoots out in 2 directions, directly to the bladder, and then feeds back down the inside of your leg to the inside of your ankle. So it's really great that we can utilize this therapy with your pants on, right? I like to joke, this is the one where you get to keep your pants on in the office. And then there's another one where you get to keep your pants on. And that is the newest addition to the therapy line that you see on the screen. And that's tibial nerve stimulation. The sort of branded name is Alta Viva, sort of attaining that higher life or better life by getting control of your urinary urgency, frequency, and leakage. This is an even smaller battery, as you can kind of sort of see down in that last picture. I know it might be hard to see, but that smaller battery, coin battery almost, just goes under the skin in that same inner ankle space. So instead of coming in every week to the office for a non-invasive external treatment, you can now have it implanted under the skin And the implants at the top and bottom of your screen last for about 10 to 15 years. And the ankle implant's an office visit. So you really can just drive yourself on out of there after you get that ankle implant. Just a little bit more information about that ankle implant, because I often get asked, you're a pelvic surgeon, why are you working on the ankle? But because that tibial nerve runs right back up the leg to the bladder, we know that when we place this small battery or small device under the skin near that tibial nerve in the ankle, it'll send an electrical pulse through the nerve back up to the bladder, just restoring normal signaling and normal functioning. And this has been long studied, over 3,000 years, through Chinese acupuncture, which is why we have the external PTNM that you can do in the office each week. So again, the technology and theory and just medical background has been known for thousands of years. And it's just great that they developed this almost permanent implant. But when you get this done, it usually is an office procedure with a very small 1/2 inch incision in the skin just behind and above the ankle bone. And once that battery slips under that skin safely, I just usually put a couple of dissolvable stitches and pull a leg compression stocking over that you'll wear for 72 hours and keep it dry. You can drive that day and do most activities, just want to avoid getting it wet for the first 72 hours and avoid submerging it in any body of water that might be considered dirty for about a month. But the benefit is just wonderful. 10 to 15 years signaling those nerves to regain and restore and maintain normal bladder function. So there are lots of people who can do the medicines and the procedures and the injections like Botox. Those are typically going to be more of a specialist, like a urologist or a urogynecologist. I am a urogynecologist. Our background after medical school is typically a 5-year residency, plus or minus, in either OBGYN, which is gynecology, or urology. And then we do an additional 3 years to be a pelvic reconstructive surgeon. And specifically, a urogynecologist or pelvic reconstructive surgeon is fixing the exit holes. So the bladder and urethra, the vagina, and the rectum. And so a lot of the neuromodulation therapies we discuss can help defecation or pooping issues as well. A urologist is someone who, after medical school, again, did a 5 or 6 year residency in just urology and no additional training after that. They typically treat men and women, and they would treat anything from kidney cancer to bladder cancer, kidney stones to urinary incontinence. Your primary care provider or gynecologist may be your first line of defense. That may be the first person you feel comfortable talking to and saying, I'm starting to wet my pants, or really worried that I might wet my pants in the middle of a movie or shopping at Kroger. And what can I do for that, right? And so a lot of primary care doctors and primary gynecologists may be able to offer you those first line therapies. Oh, I spoke ahead. I'm so sorry. But we do now know the difference between a urologist treating kidney cancer and kidney stones and a urogynecologist who only treats women and just issues with the 3 exit holes of the pelvic floor. So when is a referral needed? Great question. I give puberty seminars for young ladies around the age of 8, 9, 10. And I always say, when do you shave? And they know to answer me, when we want. When do you get a bra? When we want, right? And so I think this referral is, when do you need it, right? There's no set point that I think we're all going to agree to or definitively recommend. It's just, when do you feel it's a problem? Is it affecting your work? Is it affecting your social life or intimacy? Is it affecting your ability to socialize with your family and get back out there and see a movie and sit at a restaurant without fearing that you might wet your pants? So really, that referral is just when you feel your symptoms have reached a point where you're just done and you're ready to treat it. Now, my view of things is do it sooner than later, right? as a care provider who fixes this, it is a little easier on me to fix it at the beginning, right? It gets a little harder to treat medical conditions the longer that we've let them go on. But again, you should always ask for that referral when you feel ready. And this is such a great slide, and I'm so glad that NAFC put this information on here. A lot of us listening tonight and participating in tonight's webinar may be a caregiver. Maybe we also have a little pant wetting. I know I do, but we also are the 50 and 60-year-old children of aging parents. And as a caregiver for perhaps a child who is a paraplegic or had a spinal cord injury, spina bifida, or born with a certain anatomic defect, or as the, again, caregiver for elderly parents suffering from dementia, this is really important. It can wear on a caregiver, and that burden on you as a caregiver is absolutely the impetus to encourage and push you to ask your primary care provider or the person you're caring for, right? You can ask their physician, hey, they're having a lot of incontinence. It's creating UTIs. They're getting yeast infections. I can't change the diaper fast enough. What do I do? Because, having a wet diaper leads to that infection. That infection leads to a mental decline and then falling and femur fractures. And this can be a vicious cycle, and it's hard to break free. So speak up, speak loudly, and follow up, demand that referral, and see it through. So framing your referrals, right? I think keeping that diary, keeping that journal, making notes on your symptoms or the person you're caring for, right? And how it's impacting you emotionally, mentally, sexually, physically, right? This is important. And again, always advocate for yourself. No one will ever fault you for that. You might take a care provider by surprise, but stay the course, be clear, be direct, and say, I love you as my primary care doctor, but I think the treatment's run its course, and I would like to see a specialist, and I'd like for you to pick that specialist because you will be in communication with them. Who do you recommend, right? Or if you've researched it on the internet and have a name to suggest to your primary care provider, that would be great as well. All right, Amanda. I think Sarah is going to maybe introduce Amanda a little bit, or I know we had an introductory slide, but if I can take over, I just want to say I am super grateful for Amanda's willingness to share her story tonight. So thank you again for listening to her journey. I told her to share the good, bad, and ugly so that you get the whole transparent truth. So Amanda, it is my honor to introduce you, have you here joining us tonight. Take it away. Thanks for being here. You're amazing.
Oh, thank you for having me. I appreciate you asking me to be here. When I was in my 40s, I guess is when I started having that coughing, sneezing. And I've peed myself. And I was like, okay, this is weird. Why is this happening? So I went to my family doctor. The family doctor gave me an oral medication. Okay, we'll try it. I took that for about a year. Didn't help. Didn't really help. So I was still, coughing, sneezing, and wetting my pants. So I'm in my 40s. I'm like, I'm too young for this, right? So I went to my OBGYN. And I said, during my, I guess, annual physical probably, said, I'm having this problem when I cough or sneeze, I'm wetting my pants and I'm leaking. I was saying I was leaking. And they were asking me about the medication. I told them it didn't work. So they said there's something called, I'm going to see if I can say this right, a urethral sling, where they put something under the urethra to hold it up and help with that. So I'm like, okay, let's maybe try this. So my OBGYN did this procedure for me, and I thought, great, here we go. I'm going to be fine. So we did that procedure, and then I went on my merry way, and I still had the issues. But the issues were increasing with not just coughing, sneezing. Then I had that urgency. I'd sit at my desk at work and be like, I think I have to go to the bathroom. I would get up and the pee would come out. And so I'd be walking to the bathroom, legs crossed, trying to hold it in. And the bathroom's not that far from my office. So I'd get there and I'd be like, great, I'm wet. What do I do now? So I get toilet paper, roll it up, put it in my, in my underwear, and think, okay, now I'm going to smell. Now it's going to stink. So I'd go back to my office. I'd do my thing. Then eventually I started wearing pads, like panty liners that would help. And then as it progressed, I started moving to thicker pads. Then I went to pads that were made for incontinence, and that's what I would do. So here I am. So I'm wearing these pads every day. I'm getting up from my desk at work to go to the bathroom, getting up in the middle of the night, 2 and 3 times in the middle of the night to go to the bathroom. I'm not making it. I'm soaking these pads. I'm going through them so quickly, and I just did not want to do that anymore. The medication didn't work for me. The sling didn't really work for me. Pelvic floor therapy was not an option back then, or at least if it was, nobody told me about it. I went to my doctor and was talking to my family doctor about this. I'm soaking these pads. I'm not making it to the bathroom. Oh, and go on a trip and be in the car. It's like, where's the next rest stop? Where's the next rest stop? I got to make sure we stop and go, just so I could go to the bathroom to make sure that I'd make it to our next stop without wetting myself. And then, of course, you're sitting in a car, and then the seat gets wet. And then, a couple times I've had to put a towel down on the seat because I couldn't hold it. I couldn't make it. Really embarrassing, and worried about the smell, worried about infection, getting UTIs. I did not. I was fortunate not to get a UTI, but wearing, kind of wet pads until I could get to a bathroom to change it to a dry one, having to carry them with me everywhere I went, taking change of underwear with me, change of clothes with me, sometimes wherever I was going. And it just really got to be too much. Talking to my family doctor, I believe it was my family doctor who recommended a urogynecologist. So I made an appointment and I went. And I was given options of, different things at that time. And by now, I've probably did all those other things for a few years. So by now I'm probably 50. And I've had enough of wearing pads, soaking them, smelly, feeling bad, and I guess I was at the point at that time, diapers were my next option. And I'm like, I can't do that. I don't want to do that. So I went to my favorite urogynecologist, and she told me some options. She gave me different things to think about: implant, the Botox. And I'm like, oh, they were all very scary. I was scared. So I took the information and I read it. I talked it over, with my husband. And I decided at this point, after going through the medication, going through that, having that sling, which was not a fun process, soaking pads, ready to wear an adult diaper, I decided I'm going to do the Botox. So I went in, she explained everything to me, what she was going to do, and I did it in the office. And I believe this procedure can be done in the office if a person can, handle that. And sometimes I think patients have to go into maybe surgery to have it done. But it's uncomfortable, but oh my gosh, it's so worth it, right? I had the Botox. She walked me through every step of the way. And I left the office and I'm like, I hope this helps, praying, I hope this helps. And it did. So the Botox actually worked for me. The other things might work for you, but that's what I got to that worked for me. But I had to go, and the Botox, I believe, and Dr. Oakley can um, confirm this. I believe it might be good for some people for 6 months, some people 8 months, some people a year. But you have to go back and have it done again because the Botox, just like you put it in your face, it wears off. So the Botox does wear off, and I could feel things happening. I could feel that, oh, I had that urgency, and maybe a little pee would come out when I'm walking up the steps. Coming home from work, I drive about a half hour, and I'd go to the bathroom before I left work. I'd come home and I'd be like squeezing my legs together, walking up the steps, trying to get up there, dropping everything, and then straight to the bathroom. And I've peed a little, because the Botox was wearing off. Then I was introduced into the tibia stimulator, and I had that placed in November, and that's currently what I'm using. Still working through that. I've had a couple of adjustments made because the stimulator stimulates that nerve, like Dr. Oakley said. And some patients, I believe, need a little bit more stimulation than others. And everyone's different. So I'm in that process of using the stimulator. It has to be charged maybe once a year. I go in the office once a year, have it checked, it gets charged, and that's it. So all I have to do is pull my pant leg up instead of pulling my pants down. And I like it. I love it. It's working so far. So that's my journey.
Thank you so much, Amanda, for sharing your story. That was great.
You're so brave, and I love that you are honest about all the options. Pills are easy to take every day, but have side effects. Botox is very powerful and very effective, but you'd have to take your pants off, like you said, every 6 months, and that can become frustrating, annoying, cumbersome. And so the implants lasting 10 to 15 years are great options for the woman who just wants something to last a little bit longer. And the efficacy is 82% across the board for all of those things Amanda mentioned. And these implants do last a long time, but the ankle one does need to be charged once a year to keep that battery going. But, she hit the nail on the head. I think all of you can appreciate the moment at which Amanda said she had to put a towel in the car seat. So we've all been there. We've all considered buying diapers. There's a reason Walmart sells diapers, because we are buying them. But again, if you've heard nothing else tonight, except just that first line therapy, treat yourself, advocate for yourself like Amanda advocated for herself, and consider at least dietary changes and pelvic floor physical therapy, and then talk to your most trusted care provider about a potential referral to a urologist or urogynecologist for these advanced procedures.
Yeah. Yeah. And
I know. So I think Sarah was going to say this, but oh my gosh, being a urologist or urogyn doesn't mean that anything's wrong. It just validates that there are options and there are choices. And again, Amanda and I so appreciate the NAFC and Medtronic for letting us go through some of these choices with y'all tonight. And I know Sarah has some more resources she wants to go through with you right now. And then we will be patiently waiting for any questions y'all have after Sarah's done.
Yeah, you don't have to live with it.
Absolutely.
So when preparing for your appointment, there are a few things you can do that make it just a little bit easier for uh, the discussion to happen between you and your doctor. You can track your symptoms, like Dr. Oakley was mentioning with the bladder diary. NAFC has a free one you can download on our site. Medtronic also has the My Future app, which allows you to track your symptoms digitally. And that just really helps share with your doctor what your triggers might be, how often you're having an accident, and help maybe kind of determine more of that root cause of the incontinence. You can ask as specialists if symptoms continue or your concerns are not being heard. So, like Dr. Oakley said, don't be scared to ask for a referral. Don't be scared to ask about your treatment options. And even if it's not recommended at first, if it's something you've heard about and just want more information, your doctor's there to share that with you. And then scheduling follow-ups are really important, especially if you don't see results with your current treatment. So many people try something like a medication and it doesn't work, and then they just kind of stop it and never go back. So there's so many options beyond that that might help you. Don't just throw in the towel. Always go back in and see if something else might be appropriate. So before we wrap up, NAFC does have a ton of free resources on our site. Lots of different things you can download, tools, brochures, a bladder diary, like I said, discussion guides to help you get that started. We have really great articles and a podcast on our site that you can listen to, lots of patients and physician stories, and also great message board where you can go and talk to others like you who are struggling with urinary incontinence and are just kind of looking for someone else to talk to about it. Medtronic also has a lot of great resources. They have a great website, talkleaks.com/bladder. So they have a lot more information about their treatment options and quizzes you can take to help learn more about them. And then, of course, Alta Vivo, which we've discussed during this call. You can learn more about that at the Alta Vivo website, the My Future app, which helps you track your symptoms, and also a doctor discussion guide. So, I mean, our key takeaways, hopefully they're very clear that these conditions are really common and treatable. And there are so many things that you can do to treat them. So really, you got to work with your doctor to figure out what the best fit is for you. Don't settle for not getting treatments offered to you. Ask for a specialist if you're not seeing relief. And just feel empowered to be your own advocate. Nobody knows your body better than you do, and you're the best person to speak up and ask for help if you're not getting the results that you want. And of course, NAFC offers lots of support, so please reach out to us if you ever need anything. Visit our site, and yeah, hopefully we'll hear from you soon. So thank you so much for joining. If you guys have questions, please submit them in the chat box. I know we've been gathering some throughout the presentation, and I think Holly's going to run through some of them here. And hopefully Amanda and Dr. Oakley have some time to answer a few. If we don't get to all of them, we'll also be doing a follow-up podcast with Dr. Oakley in the future, near future. So we can discuss some of those on the podcast as well.
Awesome. Well, thank you, Dr. Oakley, Sarah, and Amanda. This was so good. We've got a lot of great feedback in the comments. Amanda, your story, I think in particular, really resonated, and people have chimed in saying your story is their story. So thank you for sharing that.
Absolutely. You're welcome.
So I'll go through, as Sarah said, I think there was a question we mentioned. We have a podcast. It is called Life Without Leaks. It's on all the major players. You can go onto our website and find it, or you can just search Life Without Leaks on Apple, Spotify, Amazon Music, and find it there. I will flip through and we'll try to get through as many questions as we can. And as Sarah said, we'll do that follow-up podcast for the ones, excuse me, that we didn't get to. So I think these are for Dr. Oakley. There's been some questions about, hold on, estrogen cream on your urethra. And the doctor, so you had mentioned it goes on your urethra, but her doctor had suggested it should go inside the vagina. Is there a difference?
Yes, let me get my model.
Yeah,
I know it's almost hard to see because it's clear and plastic, and
we
I
could see it.
apologize.
Yeah.
But if y'all are following along, obviously we have three holes, and so from the bottom is the rectum, and then the vagina, and then the bladder and pee hole. So really, if you just put a small amount, pea size or blueberry size, on your fingertip, and you rub it right at the top. So spread the labia, spread those labia out and rub it right at the top, which is your urethra opening or meatus, right above the vagina opening. Then you're getting it where it needs to be. A lot of times we will have you apply it towards the vaginal opening because you might suffer from atrophy or vaginal dryness like I do. And placing it at the vaginal opening is something very helpful every night to make sure that that skin stays moisturized. But if you're including the urethra opening and the vaginal opening, that's how you're creating not just a good layer of moisture, right? But a pH balance to prevent irritants from causing UTIs, urgency, and frequency. Now, please understand that most of the branded estrogen creams, when they went through FDA research trials, it was under the instructions to take a plastic applicator and sort of plunge it deep into the vagina 2 or 3 nights a week. And that's why your doctor may have just sort of subconsciously given you those instructions. But we specialists genuinely believe that if you want something to work, you need to do it nightly. I brush my teeth every night, right? Like there's a reason I do it every night. So the estrogen cream technically should be applied with your fingertip at the opening every single night for that efficacy in decreasing bladder symptoms. Hope that helps.
Yes, thank you. I think a follow-up is there was a question on pros and cons, or if you could maybe just speak to a cream versus estrogen tablet vaginal insert.
And again, forgive me for my drama and my bluntness. If you listen to my podcast, you understand this is the way I always talk. But if I want the face, like skin on my face to look good, I'm going to put the cream or ointment on my skin. I'm not going to swallow a pill to make my skin look better. So that's genuinely how I feel as a vaginal expert. I don't think estrogen pills or estrogen patches, right? Like any of these like transdermal patches or pills of estrogen are going to help the vagina. So that ointment or cream needs to be applied directly on that skin. Always remember your skin's the same head to toe, and all your skin needs lotion, all of it. So face, neck, belly, arms, legs, and vaginal opening. It's all skin. It all needs moisture. The pills of estrogen, the patches of estrogen, those are going to be more for systemic symptoms of menopause, which is not tonight's conversation, but we could certainly talk about that offline, or y'all can, I don't know, Holly, if you want to give me questions for later and I can answer them later.
That's good. That was all helpful. We've got a question about neuromodulation. And which is the most effective with the least side effects?
So they really are, and I giggle just because it's such a great question. So forgive me again. I wear my heart on my sleeve, so y'all get to see every single reaction. I do all three neuromodulation therapies all of the time. So I feel very experienced, having done over 1,000 sacral implants and having several patients coming in every week for the PTNM on the outside of the ankle, and being the first urogyne surgeon in the whole state of Kentucky to do the tibial nerve implant. I do feel, that I have a sense of expertise here and can really look at y'all directly in the face and say they're all equal in their efficacy. The analogy I'm going to give y'all tonight is birth control. So forgive me for that analogy, but if you really think about it, any of us as women can take a pill every day. We can have a shot every 12 weeks. We can have an implant in our arm or in our uterus, or we can get surgery to tie our tubes. And all of those are similarly effective in their efforts to prevent pregnancy. Now, we're not talking about pregnancy or birth control tonight, but I think it's a really reasonable analogy when you sort of flip that to our options for urge incontinence treatment. You can take a pill every day. You can do a Botox shot every, however many weeks that is, 24 weeks. You can get an implant in your ankle, an implant in your sacrum. You can have surgery, right? And they really are all equal in their efficacy. You really just need to pick the one that suits you the best and then follow that algorithm from your insurance, as far as them generally wanting you to try 2 pills before they'll pay for the neuromodulation therapies. But the ankle every week is effective. You just have to come in every week and potentially pay a copay. The ankle implant really is effective, but you have to be willing to have a battery behind your ankle bone, and you might not be able to wear those, Friday night heels anymore. And the battery in your sacrum's been around the longest. I think a lot of my women love the sacral implant because you do get to test it for a week externally. So you kind of get to try it before you buy it, but its efficacy is the same as the other neuromodulation therapies.
So helpful. Thank you. And I think
Yeah.
a quick follow on to that, I think this might be a broader question, but it could apply to the or neuromodulation as well, as what procedures are covered by Medicare or Medicare Advantage?
Yeah, no. Amanda may chime in. Certainly don't want to reveal any of her personal insurance coverage things, but as a care provider, the tibial nerve modulator or ankle implant is the newest. It was FDA approved just over 6 months ago, and that's been very difficult to cover through certain Medicare plans. I have personally written to the 5 biggest insurance payers to say that that's ludicrous. And so all politics aside, I think insurance wise, currently it's probably just since the PTNM external weekly treatment on the ankle and the sacral permanent implant in the tailbone have been around the longest, facilitating coverage for those just as a provider seems to be easier right now.
Yeah. Um, I think maybe quickly, but there was a question on if you could explain how Botox is done.
Oh, yeah, absolutely. Amanda, again, she described it perfectly. It can be done in the office and usually is. So I tried to do 100% of my Botox in the office because it's a 60-second procedure. Now, Amanda was also right in saying some women prefer to have it done in a hospital setting because the thought of a needle going up their urethra tube and poking their bladder while they're sitting there wide awake with me is unnerving and anxiety inducing. So I think as a care provider, I usually try to encourage my patients to do it in the office setting. So when that happens, like most urogynecologists, we will teach you a week prior how to use a small pocket catheter on yourself. There is a 20% chance that the Botox is so strong and it gets rid of your symptoms so effectively that you also can't pee at all for a couple of weeks. And you may have to gently insert that pocket catheter every morning and every night for that first week or 2. That's only a 20% risk. And I always joke, my husband doesn't help me put my own tampons in. I can find my own hole, right? So we teach y'all how to find your own pee hole a week before you get the Botox. So that's the first step. The second step is when you come in a week later for the Botox at the office setting, you are asked to arrive about 45 minutes early so that we can pour a liquid lidocaine wash into your bladder to not really fully numb it, as Amanda said, but to sort of take the edge off. And after that sits in your bladder for about 30 to 40 minutes, then I will insert a very tiny camera or scope about the size of a catheter into the pee hole so I can see what I'm doing. And, my patients watch on the TV with me. Again, that part takes 60 seconds. And we use a very small needle repeatedly in the bladder wall, just really quick, just getting that Botox throughout the whole bladder wall. And those injections take 60 seconds. But I think sitting there for 40 minutes to help numb the bladder is a really important step. But as soon as it's done, y'all can pee, put your pants on, and drive back to work. I have never had Botox anywhere in my body, so I can't speak to how that needle feels. I have had laser hair removal in my armpits, and I scream like a baby every time. But it's so quick. It's 60 seconds, and the hair is gone, and I get what I want. And so to Amanda's point, it may be uncomfortable for those 60 seconds, but it's really effective, and the Botox does work great.
Awesome. Couple questions people want to know. Do you recommend Kegels?
Not for overactive bladder or urgency incontinence. So a Kegel is when you are able to, hopefully through the guidance of a doctor of pelvic physical therapy, harness and coordinate the muscles of your pelvic floor to be stronger. So what's the worst thing y'all can do if you have a Charlie horse in your leg? Repeatedly use it. Or if you pulled a muscle in your back, you keep bending over. We would never do that, right? So what's the worst thing you can do to an overactive spastic bladder muscle? Sit there and keep Kegling it, right? That's the worst. So Kegels work really great to tighten your vagina if you don't want a vagina prolapse, which again is not tonight's topic. Kegels work great to tighten your pee hole if you don't want it to pop open and leak when you cough, but stress incontinence is not tonight's topic. So for tonight, I do not recommend Kegels, not for overactive bladder, not for urge incontinence.
That's great. Thank you. I think I've covered. Sarah, have you seen any others that we should touch on?
There were just a couple of one about vaginal probe stimulation and how it's used by physical therapists.
That's a great question. So it depends. So I'm going to kind of read into it just a little bit. There are a lot of really great probes. Companies, even like Pure Romance, offer what I would consider medical grade probes that can help strengthen your pelvic floor. A lot of them are, again, medical grade hypoallergenic silicone probes that you insert into your vagina. And the newer ones sort of Bluetooth sync with an app on your phone to let you know the strength and coordination of your pelvic floor. I think those types of probes are really great, again, for learning a Kegel and how to squeeze or tighten your vagina and pee hole. But they may be the opposite of what you want to treat tonight's focus of overactive bladder and urge incontinence. Now, the flip side of that is a lot of pelvic physical therapists. I know my team of 9 therapists use something called biofeedback. And that is just a really simple thumb-sized probe that gives the therapist a sort of graphical printout on her computer. Some of those are still wired. Some of them are wireless now. But that's a way for the therapist to coach you better through your therapy so that if you need to be Kegling, she knows how strongly you're doing it. And if you need to be relaxing, she can visualize that and sort of share that information graphically with you. So I think there's really 2 different maybe answers to that question. And maybe I'm hearing it wrong and I'm sorry.
Thanks. This may be kind of similar, but somebody's asking about a company that offers some type of treatment where you sit fully clothed on a tub and it provides stimulating massage for 10 to 12 visits. Do you know about this or have any information about it?
I'm going to assume there is something called like a blue light therapy or chair, and you do get to keep your pants on for that. So maybe that's what they're alluding to. In the medical field, there's no definitive statistically significant research that I'm aware of as of this time tonight that promotes that as a realistic treatment. However, I just did a podcast episode on things like vibration plates, and those don't have a lot of research either, but people will swear vibration plates help them with lymphatic drainage and just stability and overall wellness. So I would never discourage the use of a blue light chair therapy, but just for our listeners tonight, be cautious. A lot of these things are sort of cash only treatments. So that's cash out of your pocket. Insurance usually doesn't cover things that are not backed by research, but that doesn't mean they can't be helpful.
All right.
I've got one. Oh, go ahead, Sarah.
We have a question about when is reconstructive surgery in order? When should you consider it?
Never for tonight's topic. So tonight's topic, again, is overactive bladder and urge incontinence. That does not require surgery. So if I were to read into that question, Sarah, that person may be asking because they have been told or heard that there's something called a prolapsed bladder and that there's no such thing. So your bladder cannot prolapse, your bladder cannot drop, it cannot fall, it cannot move out of place. And as silly as this sounds, my husband's bladder is not going to fall out of his penis. Now, y'all can giggle at that, but it's true. And when you really sit and think about it, your bladder is up here. It cannot physically jump into a new hole and fall out. So the only form of prolapse is vaginal prolapse. Your vagina is a sock that turns inside out because we've used it to push humans out, right? So we give ourselves prolapse. And so prolapse is also not an emergency, but prolapse of the vagina can be fixed with reconstructive surgery, which is what I do for a living. There's just no such thing as a drop bladder or a prolapse bladder. So surgery in that description that you've given in your question has nothing to do with tonight's topic, but a great question. So thank you.
Okay, I think we have time for one more. At 79, I've never taken any estrogen. Can I start the estrogen cream now, or is it too late?
Yes, I'm interrupting. Yes, estrogen is for everybody. So it's been proven over and over again for the last 30 years that estrogen cream, topical estrogen, is safe for everybody, even if you have breast cancer or other forms of gynecologic estrogen positive cancers. So estrogen is for everyone, literally. It is just a fancy prescription strength moisturizer. Some women spend $500 on La Mer, moisturizer. Some of us just use Clinique. But estrogen cream is the best moisturizer for your urethra and vulvovaginal area. And it's no time like the present to start, y'all.
Great. Well, I want to be mindful of Dr. Oakley's and Amanda's time. And I know we have a few questions we didn't get to, but we will get to them on the podcast. So stay tuned for that. And thank you guys so much for joining us. We were so happy to have Dr. Oakley and Amanda speak and hear Amanda's story. It's just really great information and so empowering. So yeah, thank you so much. We'll send out an email in just a couple of days with the recording of the webinar and also links to all of these resources that we've mentioned. So if you didn't catch them, don't worry, it's coming to your inbox. So yeah, thank you so much. And we'll hopefully hear from you guys soon. Bye.
Thank you, everyone.
Thank you.